Okay, so this is the peripheral nervous system. All of you are probably aware of this cartoon. And then there's the dorsal root ganglion, which is an important player in the nerve conduction studies, because when we do our sensory nerve conduction studies, we are actually recording from the sensory, from the skin all the way up to the dorsal root ganglion. So that's the part of the peripheral nervous system that we are recording. And that is what we traditionally call as postganglionic. So in postganglionic disorders, the SNAP or the sensory response is affected. So I'll just refer to it as SNAP. The sensory response is affected. And usually postganglionic disorders involve pathology at the peripheral nerve or at the plexus, brachial or lumbosacral plexus. So you have a SNAP, which is of reduced amplitude. If it's a demyelinating disorder, it will also have increased latencies and reduced velocities. And the motor responses tend to be normal unless the motor axons are also affected. So on this side, you have the preganglion. So anything that's proximal to the dorsal root ganglion is what we call preganglionic. That will involve the root, the anterior horn cell, and so not exactly physiologically correctly, but we also refer to NMJ and muscle disorders saying that, oh, it's preganglionic. But technically, traditionally, preganglionic refers to root and anterior horn cell pathology. Yeah, so sorry. So in preganglionic disorders, the SNAP is normal, the sensory response is normal, the motor response is affected. That's the thing that you need to remember. This is how we record a sensory nerve action potential, or a SNAP. This is a median digital SNAP from the thumb, and this is a stimulator. This is the earth electrode. And this is what the responses look like. It's the same response recorded twice. You have something called a latency. We look at amplitude. And here you can see a little bit more clearly is a classical picture of the SNAP, where you have the amplitude. So you look at the amplitude, you look at the onset latency, which is the time it takes for the response to come up after stimulation. So this is a stimulus artifact that is produced by your electrical stimulation, and the time it takes for your SNAP to come up after the stimulus artifact is known as the onset latency. And then in certain types, so most of the time we look at onset latency for SNAP responses because we record SNAPs from digital nerves like these. But sometimes we can record from the palm, for example, and we can look at something called the peak latency. So we can still look at peak latency. And then the next parameter we look at is the sensory nerve conduction velocity, or the nerve conduction velocity in sensory nerves. And you record that by dividing the distance between stimulating and recording electrodes, in this case, divided by the latency of your response, which is this latency. Usually you tend to take an onset latency. So in a compound muscle action potential, it's similar, but slightly different because you stimulated two different points. So this is a median motor response. You're recording from the adductor pollicis brevis muscle here. You're stimulating at the wrist. You're going to stimulate proximally again, and you get a response. So this one is from the wrist, and this one is more proximally from the elbow. So you can see the latency to this response is a little bit longer because obviously it's got to traverse this part of the nerve. So this is at the wrist, so it comes up very quickly, and then this is a little bit long, and that's normal. So this is what a CMAP response looks like. Again, same thing, you look at parameters such as amplitude, you look at latency, and you look at motor conduction velocities. I'm not going to talk about duration and things. That's not required when you grossly look at these nerve conduction studies. So again, motor conduction velocity, you again calculate you using the same value. The machine will do all that for you. It will come up automatically. Distance between two stimulating points, that is here and here, divided by the proximal latency minus the distal latency. And you get values like this. For example, the stimulation site here is at the wrist. You get a latency, you get an amplitude, and then you get, and again, another latency at the elbow, which is a little bit longer than the latency at the wrist, obviously. And then you have an amplitude, and then the conduction velocity is calculated automatically for you from the software. So whenever a nerve is affected, it's very easy, actually. It gets affected in only one of two ways, either axonal damage or demyelinating damage. So axonal damage is what we see a lot in the adult world. We don't see so much of that in the pediatric world. We tend to see more demyelinating neuropathies and inherited neuropathies. But when you think about an axonal damage, the most important abnormality that you tend to see is reduced amplitude. So remember, I told you we're going to be looking at amplitude, latency, and conduction velocity. So reduced amplitude is a primary abnormality in axonal pathology. And conduction velocities and latencies are usually well preserved. As you can imagine, the myelin sheath is not that affected. So your motor conduction velocity in the nerves, in the upper limb nerves tend to be more than 45 meters per second. Lower limb nerves will be about 37 meters per second, close to 40 meters per second normally. However, if the amplitude of the response is very low, the motor conduction velocity may be slower, almost within demyelinating range, and that might be confusing, making us think that this could be primary demyelinating neuropathy. The reason that happens is because when you calculate the conduction velocity in a nerve, you're not calculating the conduction velocity in a nerve is not the average of the conduction velocity of every axon. It's actually, it reflects the conduction velocity of the fastest conducting fibers. So in an axonal pathology, if you happen to lose the fastest conducting fibers first, then your motor conduction velocity may be a little bit slower than you would normally expect. However, we do have all these criteria, and you can refer to the EFNS, that's the European Federation of Neurological Societies criteria. They have actually just upgraded that in 2021. And that tells you exactly what parameters you should be looking at, cutoff values and things like that. So then you can be really sure whether what you're looking at is a primary demyelinating problem or a primary axonal problem with loss of fast conducting fibers. So I'm just going to focus a little bit more on demyelination. So what are the electrophysiological features of demyelination? So as far as latency, so latency is the time it takes for you to give your stimulus and for the response to come up. So the sensory onset latency, sensory peak latency, and the distal motor latency, all these things tend to be increased. As you can imagine, the conduction is slower in these nerves with demyelination, and so there is increase in the latency of both the sensory response as well as the motor response. The next parameter that can be affected is the conduction velocity. And again, as you can imagine, the conduction velocity is reduced. The speed of conduction is reduced, as you can see in this response here. So this is a median CMAP, median motor study. You can see the latency has increased. Normally, the latency should be about 4.4 milliseconds or under 4 milliseconds. And here you can see it's 15.4, so that's very delayed. And the conduction velocity in the upper limbs is more than 50 meters per second. Definitely, even in elderly, it could be 45 to 50, but it should be more than 45 meters per second. And you can see it's very slow here. So conduction velocity will be slow in demyelination, and the amplitude, that's a distal motor amplitude as well as a sensory response, amplitude of sensory response, can be reduced. And that's because of secondary axonal loss, not because it's a primary axonal pathology, but it's secondary axonal loss, secondary to your primary demyelinating pathology. So the next feature that we see in demyelination is something called conduction block. We tend to see that much more often in acquired neuropathies, acquired demyelinating neuropathies. Conduction block basically means you stimulate the median nerve. This again a median motor study. You stimulate the median nerve here, you get a normal response. You stimulate the median nerve more proximally at the second site, at the cubital foci here, and you get the same size response. It could be about 10-20% slightly smaller because it can be a little bit more difficult to stimulate the median nerve at that point. In an abnormal nerve, when you stimulate the median nerve at the wrist, when I say abnormal, I mean demyelinating nerve, you stimulate the median nerve at the wrist, you get a response which is reasonable. It could be reduced if there is secondary axonal loss, or it could be completely normal, depending on the degree of demyelination that's going on. And then when you stimulate the cubital foci, you get another response which is actually reduced in amplitude. And you have to be careful. You have to make sure that it's reduced in amplitude without too much of an increase in the duration, because then that goes to another type of demyelinating parameter called temporal dispersion. I'll just show it to you in the next slide. So this is what we call conduction block. We like to think of conduction block, to be sure about a conduction block, we'd like to say it's 50% drop, but EFNS accepts 20% or 30% drop in conduction block is fine. So 30% drop in amplitude equates to kind of presence of conduction block. The only time this does not hold true is when you're stimulating very proximally up at the Erb's point. There you really need to get a 50%, you need to demonstrate 50% conduction block, not just 30%. I'm not going to go too much into these definitions, but basically 50% above is a clear, definite conduction block, although now the parameters have changed. Now they say it's about 50%, but it's still always good practice to make sure if it's 30% that the drop that you're getting, make sure that the stimulation is good enough. It's not sub-maximal, that it's supramaximal, and you're stimulating all the fibers adequately. So the final important feature of demyelination is called temporal dispersion. So this, as you can see, this looks like a conduction block. You can see the reduced amplitude. So this is a distal response. This is a proximal response. And you can see that there is a substantial reduction in the amplitude, and it looks like there's a conduction block. What there also is an increase in the duration. So remember what we said before in the previous slide, we said that we don't want a duration increase of more than 30%. And here we have a duration increase of more than 30%. So this is also a feature of demyelination. Clinically, it makes no difference. Temporal conduction block and temporal dispersion really does not clinically make much of a difference. But electrophysiologically, it's good practice to be able to recognize that this is temporal dispersion rather than conduction. So same sort of things, and that's because of different conduction velocity in different axons within the nerve. And this is what you see in acquired, because in acquired there is no uniform hypomyelination. It's more very patchy kind of myelin loss. So just quickly showing you the difference between an inherited demyelinating neuropathy such as CMT1A and an acquired demyelinating neuropathy such as CIDP. Here, as you can see, the the onion bulb, for example, collagen lamella formation is quite uniform, while here it's quite patchy, as you can see. So when it's uniform, you have an increased distal motor latency, which we know happens in demyelination. Along with that, you also have severe reduction in conduction loss, but it's quite uniform, as you can see here. While in the inherited demyelinating neuropathies, you can see that there is a conduction block with proximal stimulation, and that is because of this patchy involvement of the axons and causing this kind of, so not a uniform slowing in conduction, but there is a conduction block along with temporal dispersion, which might also happen. Now, traditionally, we always say, it was, I think, Lewis and Sutherland in the 1980s where they discovered that the inherited demyelinating neuropathies as opposed to the acquired demyelinating neuropathies don't show conduction block and temporal dispersion. In other words, acquired demyelinating neuropathies tend to show conduction block, temporal dispersion, while inherited don't. Now, recently, we do know that's not always true. So there are some exceptions. There are case reports in CMT1, PMP 22 duplications. Along with it, there are some connexin 32 cases where you can get temporal dispersion, less conduction block, more temporal dispersion, and some case reports on CMT4G. So it's not universally true, but for the most part, if you do see conduction block and temporal dispersion and non-uniform slowing in conduction velocity like this, it's fair to say that your first thought should be that this is an acquired demyelinating neuropathy. So quickly go through some a case. So just so you can have a look at the, you can see what it looks like. So this is an adult patient. He's a known diabetic and he has symmetrical weakness, proximal and distal, as you can see, opening jars, bilateral foot drop, and he's lost his reflexes. So the first thing when you look at nerve conduction studies, make sure that you look at sensory nerve conduction studies first, because that will immediately tell you whether it's preganglionic or postganglionic. You then know whether there is a peripheral nerve problem or a plexus problem, as opposed to something more in the root, anterior horn cell level, or just a pure motor. So once you look at the nerve conduction, sensory nerve conduction studies, the first thing, always good practice to do, instead of looking at the latency and conduction velocity and things like that, go first and look at the amplitude. So you see how good the amplitudes are. So here you can see that the sensory responses in the lower limbs are all absent, while in the upper limbs are also absent, but slightly asymmetrical, not dramatically so, but slightly asymmetrical. They're reduced or absent in the upper limbs. So there is some level of length-dependent involvement here, but not so much. And whichever responses you do have, they are small. I accept they're small, but you can see that there are abnormalities in the conduction parameters. So 50 meters per second and above is what you would like to see. Here you're seeing 17, 18, and latencies of 8.2, 6.8, all very, very delayed, accepting that the amplitudes are on the smaller side. When you do look at the motor conduction studies, you see similar findings. You see that the amplitudes are reduced, but still present more than 1 millivolt, and the latencies are increased. You have normative data. Everybody, I'm sure all of you who do electrophysiology, you know that there is normative data. You use that. And you see the conduction velocities, which are also slowed. It should be more than 50 meters per second, if possible, well, more than 45 at least. And here you have something quite significantly slowed. According to the EFNS criteria at the moment, it's 30% below the lower limit of normal. So if your lower limit of normal for conduction velocity is 50 meters per second, in the upper limbs, then the cutoff that you'll be looking at for conduction velocity slowing is 35 meters per second. It's always helpful to write this down, to type it up and put it on your in your lab, on a wall in the lab, so you can just quickly look, and then you know that you're dealing with clear demyelination as opposed to a mixed axonal and demyelinating neuropathy. So you can see the same thing here, very reduced conduction velocities. Only thing is when you have amplitudes which are quite low, below 1 millivolt, as you can see here in the tibial and tibial nerve and the peroneal nerve from the tibialis anterior, to be a little bit more careful before calling it as a abnormal conduction velocity, because it can look very spread, the response, and it might be difficult for you to know where exactly to place your cursor. So I'm just concluding with 2 slides. This is more specifically for our pediatric group today. So this is taken from a muscle nerve review article from Mayo. So there they used sort of the motor conduction velocity parameters, and they used ulnar nerve. Conventionally, they were using the ulnar nerve, and they showed how you could use the conduction velocity parameters to decide which genes to first test for. And this group, a couple of years earlier, actually went a step further, and they divided it into very slow motor nerve conduction velocities. And this is based on upper limb nerves, because lower limb responses tend to be absent in these inherited demyelinating neuropathies in the vast majority of cases. So they depend on the upper limb nerves. So very slow is less than 15 meters per second. Slow is 15 to 35 meters per second, and 35 to 45 they classified as intermediate slowing. And they sort of gave little, they found that in their group of about 700, cohort of 700 odd patients, they found that testing for PMP or MPZ very slow would be the best way forwards first. And the same goes for slow, 50 to 35, you could first test for PMP and CMT1X, and very rarely they found these mutations. And for conduction velocities with the intermediate range, obviously you go for GJB1, the connexin 32, MPZ. And if there is male-to-male transmission, then they suggested trying testing for CMT1B. And or you can also have these kind of intermediate conduction abnormalities in HNPP as well. So that's it. I'll just stop sharing my screen.
So thank you so much, Dr. Radhika, for taking us comprehensively through. We are very honored that there are just so many participants today, especially very, very eminent people. Thank you so much, Dr. Manoj, for staying awake in the middle of the night in Australia. It's more than 10:30. It must be 12:45 there. Would you like to make any comments before we start presenting? We've got difficult cases ready for you. Cases from Pune and cases from Birmingham and cases from all over. Would you like to comment anything, Dr. Manoj?
No, that was excellent. I enjoyed that talk on. Can you hear me?
Yeah, you're very audible.
No, that's excellent. Sorry, I logged on a little late, but I enjoyed that discussion on the electrophysiology. That was a nice talk. I enjoyed that. Thank you for having me. Look, I'll be interested in listening to the cases, but I'll be interested in what everyone else thinks. There seems to be a huge amount of expertise in all the people attending the meeting, so it'll be nice.
We are trying to get better with neuropathy, because in the pediatric neuromuscular world we are not so good with neuropathy. We're a little weaker on it. So there are a couple of experts in the country like Dr. Umesh in Pune, Dr. Renu in Chandigarh, and I can see there are some of my adult colleagues from NIMANS, and Dr. Shruti is there from Sri Chitra, Dr. Sarath. These are people who are co-hosting kind of thing. All of you are the co-hosts. So I'm going to invite Dr. Umesh to present quickly. So what we decided was Dr. Umesh had a couple of slides. We, as the home team, had more slides, but we will take last. If we run over time, we won't present this time, we'll do it next time. So next would be Dr. Vail Murugan, followed by the Chandigarh team. So on to you, Dr. Umesh. If you can screen share and start.
Yeah, thank you, Anne. So without wasting much time, I will start with my case presentations. So just have a look at it. Discuss the map. So just go through it if you want. I can add another. Your email ID. So my slide is visible.
No, it's not visible yet.
It's not.
Your desk is visible, your desktop.
Is it visible? Why is
For some reason, it's not visible.
okay.
So Dr. Murugan, there was some problem with your slides. So it might be better if you do it directly yourself, because you're the next presenting team.
Is it visible now? I'm getting here message your screen sharing is paused. Is it from my end, or I think the previous speaker has stopped sharing or something like that?
It says no, because we are seeing your screen, but we are not getting a PowerPoint. It is your screen that we're seeing.
Now?
Nope.
I'm able to see my PowerPoint.
It is showing as you're viewing Dr. Umesh Kalani's screen, but the presentation is not getting projected.
Resume share now.
Why don't you stop screen share and then restart?
Okay, okay. Okay, now?
Yeah, yeah.
Okay,
Visible.
yeah, good. Okay. So thank you very much, Anne, for organizing this monthly neuromuscular symposium. It's very interesting, interacting CMA. Thank you, Dr. Manoj, being there in the midnight. And I have these 1 or 2 cases. This is one interesting case which is with me since last 8 years, and where we need experts' opinion on this. So this girl, she was presented to me at the age of 8 years. Now she is almost 16-year-old. And she was first by birth ordered non-consanguineous marriage, and she was presented with history of foot drop since few months prior to presentation. Otherwise, there was normal birth history, development, everything was normal, no history of trauma, any ulcers or any wasting obvious, any surgeries done in the past. She had more distal weakness and slight asymmetry was there. She has hyporeflexia and preserved position and vibration sensor. This is the video at that time. She had a clear-cut foot drop within few months. Slight progression, mild asymmetry was there, foot drop, but there was not much proximal weakness. I am just running through the videos, so one can see the progression over a few months. This video, I think, after 2 years, the same girl, she has definite distal weakness, but not much proximal weakness. She can squat, get up very well, and she has hyporeflexia. Though, so semiology was clinically, it was looking like a hereditary sensory motor neuropathy progression, very slow progression over a few months to a year. A neurophysiology study showed both peroneal absent with low amplitudes with preserved latencies. So more of an axonal kind of thing, but EMG showed very classical spontaneous fibrillations in the lower limb. So we thought whether it is subacute degeneration, axonal, or some kind of distal HMN like presentation. Her metabolic workup was normal. CSF studies were normal, including lactates. One biopsy was done that time, which showed only mild axonopathy features from the Niemanns. So it was not conclusive of any particular type of HSMN or HMN. Giving a typical presentation, we gave a trial of 5 days of steroids. There was no effect, so we stopped it. And there was gradual progression. So repeat EMG was done after 1.5 years. And it showed still fasciculate, very well positive sharp waves and fibrillations, right TA, as well as in the now in the upper limb, dorsal interosseous muscle. So something going on acute on chronic here. And we have done, we asked to do SMA workup also, suspecting whether it is some unusual type of SMA, 5Q, although there was more distal, but it was MLP was negative. So we thought some non-5Q SMA. PMP22 deletion duplication was also ordered, although it was not a classical demyelinating, but it was easier to do, less costly investigations as first line. And then after it was negative, neuropathy panel was asked. Our thought was whether it is a distal SMA, although odd age of presentation starts with lower limb and then involving upper limb. And simultaneously, we were evaluating her for any possible acquired cause which is treatable. So lead poisoning workup was negative, porphyria workup was negative, vitamin B12 deficiency was also ruled out, and she was not on any drugs. So we got this ACTX mutation heterozygous of US on genetics. And so any thought on this? Hello? And
yes, sir. Sorry, is that a question for me?
yeah, yes, sir, of course. Or anyone can also comment on this.
Yeah, I'd be eager to see what the others thought too. What do the others think? I just had a few more questions. Was the alpha fetoprotein raised?
No, beta lipoproteins. We for ataxatilin's it is you want to say, sir?
No, but even but even with senataxin mutation, sometimes you can get a rise in your alpha fetoproteins.
No, we haven't done it. We haven't. I didn't. But it's a good thought that we can think about it to them. I haven't ordered alpha fetoproteins for her.
And did she have pes cavus and other foot deformities?
No pes cavus. No foot deformities or spinal deformities.
Okay. And any oculomotor apraxia?
No oculomotor. See, the cranial nerves were intact. She did not have any facial weakness or extraocular muscle involvement. It is only distal, and which was very slowly progressive.
Asymmetric. There's a question on whether there is wasting of muscles or if there's family history of something or asymmetric muscle wasting.
Mild asymmetry was there, not very striking. But yes, we thought of it. So we continued. We did not have any diagnosis that time. And then we thought it could be distal SMA, ACTX. She was not having all the features of ACTX, but we tested in parents, and mother has the same mutation, and she was asymptomatic, and her NCB study was also normal. So probably this mutation was not explaining her all features, although it is described with juvenile amyotrophic ALS. But she had a neurophysiological features of acute and chronic denervation, but it was not fitting into all the genotypic match. We even asked them to review, but no other genes we were able to get. So the story continued, and then after a few years, now she is 16-year-old. After 7 years of follow-up, she is having the same features. There is slight progression now. Foot drop is there. Still no proximal weakness. Significant foot drop. Now there is no asymmetry, and
something about
she can jump. You can see she can jump.
No fasciculations, no UMN signs, no
Pardon?
No fasciculations, no
clinical fasciculations or any tremors.
Questions, okay.
So proximal weakness, still she is very well preserved.
So and how do we take this forward?
Yeah, and then the story continued. Her younger sibling presented after the first child in the disease. After 3-4 years, she started having the same symptoms at around 19 years of age, same age. Foot drop.
अभी तू बेटा मुझे पंजे पे चल के दिखा.
No proximal weakness. Only foot drop. And there is third-degree consanguinity here. I forgot to tell that. Same kind of presentation. Her EMG was almost same. There was axonal neuropathy, possible distal HMA. Same kind of presentation. So she has hyporeplexia. And now, so we asked to genetics for this child from other lab now. And this other lab also gave the same mutation, SCTX1 they found, and then this TFG mutation, which was also not classically explaining all the features. So I'm now stuck here. What to do now?
Dr. Manoj, any suggestions? What should we be doing?
Look, I'd be eager for other comments. My comments are: you got two siblings who are similarly affected in a family with consanguinity. So I don't think there's any argument that this is
Genetic.
an inherited neuropathy. The neurophysiology is characteristic of an axonal sensory motor neuropathy. The first thing we can say is, so senetaxin mutations with aprotaxin and the ataxia telangiectasia are found in a group of disorders called ataxia with oculomotor apraxia. So the dominant mutations that they mention there are, it's a risk factor for adult onset ALS. So I think we can exclude that. But in the recessive form, so if you find another mutation, they are the cause of AOA2, I think, which is ataxia with oculomotor apraxia. Very, very rarely, there are families initially presenting as CMT. Later, it becomes more apparent that they actually have an cerebellar ataxia. So I don't know TFG mutations. I've never come across a family with TFG, so I'll have to read up on that. I haven't come across that as a pediatric onset. So if Dr. Kalane has more information on that change, I'd be interested. But the senetaxin, I think, is interesting in this family, especially with the history of consanguinity. You only found one mutation. You'll have to look hard, I suggest, for a second mutation and examine this girl and see if you can find any other evidence that would be consistent with the AOA2, which is do the alpha fetoprotein, and really check if she has any other oculomotor apraxia. I don't know which gene senetaxin is found on, but you can look for another mutation in senetaxin on this thing, either looking for a large deletion that you missed by doing a high res chromosomal microarray of that allele, or looking for a intronic mutation. I wouldn't completely exclude that they have a presentation of AOA2. Those are my suggestions. I'd be eager to know what the others think.
Yeah. And you can ask anyone. Anyone?
I think everyone's equally stumped.
Hi, am I audible? I am Dr. Shruti.
Yes.
Yeah.
Hi, Dr. Shruti.
Yeah.
Good to hear from you.
Yeah, Dr. Kalane, wonderful case, and I think nobody can possibly go beyond what Manoj just told regarding the genetic evaluation of it. I'd be interested in just confirming two things. The sensory involvement is clinically as well as electrically there, right?
Sensory involvement is not there.
It's not there because in the second patient, you had actually, it was written that hereditary sensory motor neuropathy in the nerve conduction. So if sensory is not there, it is actually a bit, it is a bit, the fact that the child can jump is a bit odd to me, because usually when you have plantar flexion weakness, you can't jump. So is it a pure dorsiflexion weakness? Does she not have a weakness of plantar flexion?
No, not much. She was able to walk on the toe. And that's why we thought distal HMN, more possibility. And it's very rare in pediatric population. I haven't seen much cases of distal HMN. She had all the odd features for the classical HSMN. No proximal weakness, not much progression over 8 years, and starts with the legs and then involving now upper limbs. And the same age, the younger siblings started presenting. And she's also, so we have done biopsy once, which did not show any significant features on biopsy from Lemans on, like they mentioned, just mild axonal neuropathy. So it is also confusing.
That the problem may be that you've taken a sensory nerve because the patient has a pure motor phenotype.
It's very difficult to take motor now.
Yeah,
for biopsy,
okay, we can't do that. So my additional point here is that if it's one possibility is definitely dyslexia. Is there any possibility of a distal myopathy? Like if there is a one way you may, you showed a lot of fibrillations and positives, but if EMG in a child is so difficult, so I know that it is not a easy thing to do, but if it is something which you would like to see again, if there is a specific weakness of one muscle over the other, in the form of dorsiflexion being extremely weak, you can also see proximal whether adductor abductor is there any difference or not. If any such thing is seen or if CPK is elevated, that is one rare possibility that you may want to consider. If a lot of discrepancy is there.
I think we have done almost 4 or 5 times EMG for both the kids, and it's like axonal neuropathy. Myopathy will never give this chronic degeneration pattern. So and CPK was also normal, and the involvement was in the upper limb also. That we tested for dorsal interossea as well as flexors and extensors of the arm, proximal muscles of the upper limb. All were involved. Only thing that the spontaneous activity was more in the distal muscles. So I haven't seen much this kind of myopathy, focal myopathy in pediatric population. So that is also a very odd clinical presentation to have such. But this is a good thought, I think.
I fully agree. I just wanted to add some because dyslexia is what you have been thinking of all along, and I think it clearly fits the clinical picture.
And Dr. Shruti, if that's the case, wouldn't it be possible to say myopathy? Often I remember Dr. Radhika drilling it into my head, saying that sometimes EMG you cannot pick up. EMG can be normal in the myopathy.
Yes.
It's subtle and it's patchy and all of those things. But muscle MRI is more subtle than that. Would be able to have better yield, especially in a child over 7 years, if you do a proper neuromuscular protocol.
Yeah, I agree with you to some extent. In the thing that muscle MRI may not be able to differentiate between a myogenic versus neurogenic. It will show you the patterns. So
it would show you, but sometimes there's more rounding and all that. Anyway, you're fishing in the dark.
No, here I think clinically would be the best way to go about it. Sure. If Dr. Kalene is pretty much sure that it is distal interossea and lumbricals and all the distal toe muscles which are weak, then it is not myopathy. But the only thing is that if it is just foot drop and the distal most muscles are not affected, then you should be careful. Like the toe and the fingers, these are not affected, but it is the ankle which is more weak. Then I think probably you should think about the other one. But otherwise, I think you may want to consider if there is, rephenotyping to see if there are any features of ataxia. I mean, everything Dr. Manoj has mentioned.
So the other question I'm asking, I've asked, I think I'm also reading out from the chat box, and Dr. Manoj and to you, the experts, is that so somebody asked, Dr. Vaishak Anand has asked about MLPA being done for SETX. But the thing is that this is you're expecting homozygous consanguinity here. So why would one be a point mutation and the other be a deletion, which you have to hunt for with an MLPA? How valid would that be? What are your thoughts on it? And FALS is what somebody else has asked. Maybe the phenotype will become more obvious in time. What are your thoughts?
So you're just looking for compound heterozygous mutations. I know with consanguinity, you're expecting that they're going to have the same mutation on both alleles, but it doesn't have to be the case, The consanguinity may be just incidental, but what they have is autosomal recessive with 2 different heterozygous mutations. So it's our practice, if we find one mutation in a family where the phenotype is consistent with the disorder, we go looking quite strongly for another mutation or a deletion. Sometimes some of these are not picked up on panels on the other alleles. So I would agree with that completely. We would do either a high-res chromosomal microarray or an MLPA if one is available for that allele to look for both another mutation as well as a deletion.
That's a great comment. And that's the suggestion we've got, Dr. Umesh, for you.
I got it. We need to find out if there is any deletion duplication for the same gene.
High-res array might be a better answer.
Only thing is that the mother had the same mutation. That's why we thought.
But high-res.
Yeah, mom's going to be carrying one mutation. The question is,
The other
has
mutation.
she inherited something else from dad, either a intronic mutation or the intronic mutation would be very difficult to find, but you can try and find a deletion that maybe dad and the siblings both carry.
So shall we move on to the next one?
Ma'am, I think Dr. Renu ma'am has raised hand.
Okay, Dr. Renu, would you like to make a comment? Dr. Renu?
Right, I just want to make short comment because I feel if the snaps are absolutely okay and it is predominantly motor involvement, I would also think if and the EMG is neurogenic. So I will also go for some non-5Q SMA with distal predominant weakness. So SMA, LED, that kind of variant may be possible. Other possibility from my side is again distal HMN with lower limb onset and upper limb definitely involvement is there. And muscle biopsy may confirm these findings if you can do it in the patient. If you then you can show group atrophy or specific atrophy of type 1 fibers, then your case may be strong for further evaluation of 9-5Q SMA group of disorder.
Yeah, that's what we decided. That the good part was that since 8 years there was not much progression for the child. So what we decided that we will at present keep a close watch on them. Maybe new mutations or new things might come in next 1 or 2 years. Reevaluate again the genetic material what we are having with the labs. We have kept it with them, and as Dr. Manoj has suggested, maybe that time we can additionally do MLPA testing or array for this particular SATX mutation, and she might develop other features like apraxia or ataxia afterwards. So accordingly, we will investigate. So that is one good part is that since 8 years, not much deterioration. So they are also having patience with me, and I was able to investigate them till this day.
Okay,
Thank
so
you.
I would just second that. We've published a few cases with BICD2 and DYNC1H1 mutation, very static progress causing distal HMN. So if the neurophysiology doesn't show any sensory involvement and there is that degree of denervation on the EMG, then distal HMN is a possibility. So in those cases, there is a characteristic MRI appearance. So like others said earlier, I would think of doing a muscle MRI. There are some very characteristic features for big D2 and dynein heavy chain.
Yeah, thank you.
shall we go to the next one?
Yeah, can I go to the next case, Anne?
Yeah, but is it your, if it is a regular case, then shall we keep it to the next time?
Yeah, one not regular, one on the opinion. Okay. 3-4 slides only.
Okay, sure.
Yeah. Okay. Or and I can do it next time also. You suggest me. It's fine.
No,
I can
you finish it off quickly because the Birmingham team has to do it next. You finish it quickly. I'm very conscious that it is getting late for Dr. Manoj.
No, that's fine. I'm awake anyway, so let's keep going.
Oh dear. Okay.
So, are you able to see my screen?
Yeah, you're visible.
Okay. So I just rest of the cases we can show later on. Just want an opinion on this case. So this is now a 14-year-old boy. He was again presented with distal weakness, with some foot deformities, significant asymmetry right side more than left, and some proximal weakness also. There is wasting, and this was going on since last few years. So distal weakness, mild asymmetry, mainly motor, and again EMG showed axonal neuropathy. But the only interesting thing was he was presented with somebody did the MRI, and MRI was showing this cerebellar hyperintensity is bilaterally symmetrical and mild cerebellar atrophy, not very significant. And on that basis, it was suggested it could be possible INAD or GAN variant of neuroaxonal dystrophy. And we did this. These were the MRI changes in the cerebellum. Rest of the MRI was normal. Brain MRI was normal, and same with some cystic changes in that. And it came positive for GDAP1. So I tried to search for GDAP1 with this kind of cerebellar hyperintensities. HSMN is being known to have some MRI brain changes in cerebellar volume losses, but hyperintensity is not much described with GDP1A. So what is the expert's opinion on this?
Eager again to see what the others think. I have not found a family with GDAP1 is a rare mutation, usually causing a recessive axonal neuropathy. I'm not sure, what does it show here?
On MRI, hyperintensity.
No. Sorry, the genetics, what did they show? That they had a dominant change in which one's the proband there?
Yeah, this is the
the first one. Yeah, he's got recessive
mutation.
Yep, yeah. And his neurophysiology shows an axonal
neuropathy.
Yep, with some proximal involvement.
Yes, distal more than proximal.
And does he have any vocal cord involvement?
No vocal cord. It has been described with GDAP1, but no vocal cord involvement. He was having no speech issues or nothing like that.
Right, and and he's got a slowly progressive,
yes, definitely progressive
course. Yeah, and any cerebellar signs otherwise clinically?
No, he was not having any obvious ataxia. It was all because of his weakness. He was not able to walk properly. But no other cerebellar signs like dysdiadokinesias or any tremors or any ocular findings. Only this incident, this MRI was done for other purpose from outside, and we got these findings.
Yeah, I think it's quite interesting. Otherwise, his phenotype would fit a recessive GDAP1 mutation. How severe is he now?
His has progressed. He's still able to walk, but now he requires support for walking.
Yeah, look, that's a quite characteristic feature of GDAP1. They are quite significantly progressive. All my patients are in a wheelchair in the second decade of life. So I think the clinical phenotype fits. I'm not sure about why he has those cerebellar changes. My suggestion would be to MRI again in a couple of years, if that is relevant, to see if there is any progression. And we think what the others thought.
Could I ask something? Is this a consanguineous family? Sorry, I missed that.
I think I am not having any information at present. Probably yes.
Because the reason is there's so much consanguinity in India. Can it be that he's got two things? Other than the GDAP, which fits the phenotype, does he have something else?
Or else, can it be a finding associated with GDAP1? Maybe more and more cases we will find it, because many times with the advent of genetics and being description of new genes with these phenotypes, HSMN is being known to have cerebellar changes, but this kind of changes maybe in future we will see quite often. Hello,
Dr. Sharath, would you like to comment anything? Dr. Shruti and Dr. Sharath?
No, I think clinically. Sorry, Sharath, please go on.
Yeah, I think it's a very rare phenotype anyway. It's GDAP, but we have seen CMTs usually with the connexin 32 mutation presenting with hyperintensities. So I don't know, I haven't got any case like with GDAP with the cerebellar hyperintensities, but there are other variants like connexin 32, CMTX and all can have hyperintensity. So we don't know. Maybe we need to follow it up and get the MRI done on a later stage.
And I just, very interestingly, when you told about this, I just typed it in. I just found a case report where there is a cerebellar hyperintensity with GDAP1. So I think, clinically it does fit with GDAP1.
Yeah, clinically it looks like GDAP1.
So it may be just one of the phenotypic presentations. That's a 2017 report I just found. I didn't know that before.
Yeah, even I got one reference after seeing this case. Before that, even I was not knowing that this kind of, I've seen this with INAID GAN, but not with other HSMN so commonly.
That you have a question asking if there's any autonomic features.
No.
Okay, so then shall we move on to the next case?
Yeah. Shall I stop sharing, Anne?
Yes, please.
Okay,
Dr.
thank you.
Murugan,
Thank you.
are you ready, Dr. Murugan? Thank you so much, Dr. Kalani. The fantastic cases.
Thank you. Thank you, Anne. Yeah.
Thank you. Dr. Murugan, are you ready to go ahead? Dr. Murugan? Sir, Dr. Murugan? Dr. Murugan, you are one of the co-hosts.
Yeah. Can you hear me? Yeah. Can you hear me?
Yes, you're audible. You're audible. Please start sharing. I think you're sharing.
Can you see the
Yes,
screen?
visible. Fantastic.
Okay.
Thank you for being here, Dr.
Good
Murugan.
evening.
Is the clinical lead from Birmingham Children's Hospital, and many of us know him. Please go ahead, Dr. Murugan.
Okay. Okay. Good evening to everyone. So I think this is kind of a interesting case in a way that once in a while we come across a diagnostic therapeutic dilemma, actually. So as you go along, you'll get, I put a couple of slides there to interest the postgraduates in the audience, because it's very easy in a neurology meeting to speak hi-fi stuff, and some of the audience can be lost along the way. So it may sound basic, but yeah. So let's get started. This is a 17-year-old boy we saw in our surgical ward. We are asked to see with this history of 5 to 6 weeks history of reduced sensation in both feet and difficulty in the walking for 2 weeks, and then foot drop was obvious in that surgical admission. Again, the story was the foot drop was for 2 weeks. And so with this background, previously he was born one of the twin, is well normal development, but he was known to have a toe walking. From the start, he was very thin built. The surgical diagnosis is he got superior mesenteric artery syndrome. Short form is SMA. It is not the SMA this learned audience know about. So it's a very surgical condition, and he had 3 major surgeries and developed a lot of complications. He's known to have poor weight gain throughout his life. And what is the superior mesenteric syndrome? I Googled it. This is what I found. Aorta, superior mesenteric artery, is supposed to have a fat pad around the duodenum at the 3rd part of the duodenum. When the fat pad is lost, the branch of the artery, like superior mesenteric artery and the aorta, squash the 3rd part of the duodenum, end up developing a chronic obstruction. That leads to abdominal pain, fullness, nausea, vomiting. That's how they present. It's very difficult to manage surgically. You have to resect one of the vessels. You can see the feature, complete bowel ischemia and the bowel being lost. That cannot be done. The surgeons are trying to do mechanically, relieve the obstruction. That is not happening in this case in spite of these surgeries. So this recent weakness is a new thing in addition to the mobility he's experiencing. On examination, he showed bilateral foot drop and reduced sensation below the knee, and the reflexes were reduced in the lower limbs. Rest of the upper limb examination is normal. Can you see the video playing?
Yes, sir.
Yeah. I think those postgraduates, watch the video as though horse is walking. When you see somebody walking like a horse, imagine that patient is having a foot drop. It's a simple analogy kind of to think. When you see somebody, gait can teach a lot of neurology. And this is one of the classic example. And so one of the things he was giving when I saw him in the surgical ward is that I felt that there was a distal muscle wasting I could see. There is a kind of, again, the distal half of the leg was again wasted. It is a chronic process than the story we were told. And so that's, again, you can see the very flat feet also he has. again, if the story is long, it fit in with like a CMT kind of way and a clinical examination. So our initial, because of the short story, these were our differential diagnosis, and we went ahead with the nerve conduction EMG studies. This is what it showed. Sensory motor demyelinating polyneuropathy affecting upper and lower limbs, predominantly the lower limbs, and there was secondary axonal loss affecting the distal muscles. And our neurophysiologist conclusion was being abrupt onset considered CADP, abrupt onset CADP or GBS. Again, the findings were confused with increased enhancement of the nerves, particularly ventrally. Enhancement of the chorda equina excites the neurologist towards Guillain-Barré syndrome. And I was doing some research at the time. This is also known to happen in some of the case reports I have seen in CMT also. And you can see the CSF protein is raised very high, and the institutional test, including folate P2 level and celiac antibodies, were negative. While waiting, we started treating him, actually considering CADP as a possibility because it's a treatable condition. So we have sent the whole genome sequencing nowadays. That is one of our first line investigation in National Health Service whenever we want a genetic panel. So we have given a course of IVIG, at least 2 courses by now. We started him on steroids, and we went down the prednisolone, and we have went for dexamethasone. Dexamethasone is currently on. But the normal improvement I tend to see in other CADP, which is not happening yet. Almost very little improvement we have seen in spite of all this therapeutic intervention. Even before starting this, I had a doubt, is it CADP really clinically? That's a question. I'm going to show the full report of the the nerve condition our neurophysiologist made. I kind of look out for the experts' comment on this. Okay, I think the neurophysiology, I think I mentioned the summary, and this is a conclusion of our neurophysiologist: sensory motor demyelinating peripheral neuropathy affecting upper and lower limbs, and more severe involvement of the lower limbs. With already I read out these findings. So, and these differentials were abrupt onset CADP versus Guillain-Barré syndrome, and consider the nutritional causes. So I'm going this page. Can you see this page?
No, we are not seeing the neurophysiology. We are still seeing the PowerPoint.
Oh, sorry. Okay.
Meanwhile, there are questions on if there is any vasculitis or PAN or hepatitis serology. What the hepatitis serology was?
I think the autoimmune screen we sent, they are negative. I don't think we did a hepatitis serology.
No, we didn't.
Let me quickly check whether I can get that page.
If we unshare, share again. Share screen. We'll go to that. And then
Can you see the report page?
Yeah, we can see it.
Okay, so this is the the motor conduction studies on the top, and I'm just moving the slide slowly so that neurophysiology colleagues can look at the report. Okay, I think this is kind of in a normal neurology wards, and I think at least in the last 5 years here, I have seen a couple of patients like that. Both the patients I went on treating like a CAGP when this differential diagnosis is offered to us. The first patient came out with a normal genetic studies, and she clinically improved, almost similar age, not similar, she was 15 years old. But this boy, in spite of IVIG and steroid ongoing, and he hasn't shown the improvement I expected. Again, from the start, I felt we are overdoing it in terms of therapeutic intervention. So the question I asked our neurophysiologist, can you differentiate the two based on the neurophysiology? And again, he felt himself, it's not that difficult. It's kind of from neurophysiology results, you cannot say black and white either way. And so I would look for comments from the panelists that can you make out something with this story and then this neurophysiology report like this? Because waiting for, at least here, though whole genome sequencing is available, we have to wait for the results sometime between 6 to 12 months before we know the results. But by the time patient would be very handicapped with this disability, and it's a treatable disorder. That's why we went into this. And we don't do often like that, but this is the second case I've seen in 5 years. Yeah.
So there's 2 questions from the audience. One of the questions is whether treatments like cyclophosphamide help and whether there was anything relevant from the superior mesenteric artery thrombosis. But before that, I want to ask Dr. Manoj, because we were stuck with a similar thing recently, and Dr. Manoj helped us on telling us that neurophysiology doesn't help us in the short term. Dr. Manoj, would you like to comment?
Well, I think neurophysiology can be very useful in differentiating, as the first speaker said, if there are certain positive signs. So in this one, you can see, there is a length-dependent pattern to it. So lower limb motor amplitudes are completely absent. Upper limb are relatively well preserved. The sorry, there is sensory motor involvement. There is no question it's a demyelinating neuropathy. The motor conduction velocities in the upper limb are relatively similarly reduced. They are 28 and 31. I don't know if you can go down a little bit more meters per second. So they're quite similar. I haven't had time to look at it in detail, but there's no conduction block and temporal. Well, I can't look for temporal block there, though not all the responses seem to be supra-maximal. So that plus the fact that you had no response to a trial of both IVIG and steroids. Now with that and the clinical history, I guess you could think that this is going to be genetic neuropathy. So our usual thing. So the first thing is, yes, neurophysiology I think is very important to do well and repeat right at the beginning. If you have some certain positive features, asymmetry, conduction block, temporal dispersion, non-length dependent, it can be very useful in differentiating the two. In the absence of it, I think it's very reasonable to give a 3-month course of IVIG or steroids. If negative, I would then go on to do genetic testing, just like the Birmingham team has done.
So thank you. There is a Dr. Urvi. Thank you for being here. Dr. Urvi is a neuromuscular specialist from the US. I'm not sure East Coast or West Coast. She has asked a question in the chat box asking, if there's any way to share the waveforms. Dr. Murugan, if you can send me a screenshot, I can send it there.
No, not on this report, maybe on the neurophysiology system, but not on this report. Only whatever I have, I shared.
Okay, sure. So it looks like we are running over time. We've got a plethora of experts here, including Dr. Sharad, who is an expert. He's a neuropathy expert who specializes more in the autonomic nervous system. We're just very lucky that we had Dr. Manoj with us. There's, other than you had one more case, or this was your case?
This is only case, yeah.
Okay, so we had 3 cases, and PJ team has got 3 cases with 1 difficult case. Dr. Manoj, shall we stop here, or shall we do 1 difficult case from PJ and then stop?
No, I'm happy to do another one. But
Okay.
sorry, I was just checking, what was the outcome for this one? Did you have a result on genetic testing?
No, not yet. So we're still waiting for. That's where, you know, that can take some time. And we have a plan to try this for 3 months, already 2 months over. We are going to give one more cycle of IVIG and then we are going to stop it.
Yeah,
can I add this?
Yeah.
Regarding historically also this patient had toe walking, right?
Yeah.
So that also it looks into it could be a kind of inherited CMT also, and I think there is case report of SMA related to CMT, superior mesenteric block. I feel that electrophysiology is also a little more into the inherited neuropathy than the CADP. There's no conduction block and it's more generalized. I would feel that as told by the other experts, it could be inherited CMT only. I would say. I think the toe walking and the SMA are all related actually.
Okay. Yeah, because the SMA I haven't come across. This is the first case I have come across and with the neuropathy. And
I think few cases are there, I think with the CMT.
So Dr. Sharath is the other expert panelist who is from Aster and Kochi, who specializes in autonomic nervous system. So sorry, Dr. Sharath, we may have to postpone your talk to the next time.
Yeah. Sure.
First talk next time.
Yeah. No, sure.
We're going to have neuropathy part 2. So we'll finish with Dr. Renu, if you wouldn't mind just doing one difficult case before Dr. Manoj disappears.
Right, we'll do the first case only, and later
difficult one. The difficult one.
Difficult one, right?
Sorry, Dr. Manoj, we're keeping only difficult ones for you.
So allow me to share my screen.
Ma'am, you're the co-host. I think you can share.
You should be able to give a screen share.
It's just say one participant can share at a time.
1 second. Currently, no one is sharing the screen, ma'am.
Yeah. Okay, so my slides are visible.
Yes, they are.
Yeah, so thanks, Dr. N, for giving this opportunity. So I'll go directly to the case. So we have a 7-year-old boy who was presented to us with complaint of progressive weakness of both upper and lower limbs since 3 years of age. So his development was normal till 13 months of age, and by 2.5 to 3 years, he started. Just a second. Yeah, so initially he had bits of pain in the arms bilaterally, and within 1 week or so, he was noted to have weakness of bilateral hands, which was like clawing of the hands, where he was not able to do fine activities from the hand. And within like 6 months or a year, his developed completely wrist drop, both shoulders as well as elbow was completely weak, and they was like hanging from the side of the body loosely, and they remained like that for the next 5 or 6 years till he presented to us. He was not able to move at all fingers and wrist voluntarily. And by 6 years of age, he also noted to have gait changes where there is slippage of sleeper. He was not able to move feet at the ankle and was not able to move the toes. He became very thin and he started having recurrent falls. Proximal weakness started with difficulty in getting up from supine position also. And a bit of facial weakness was also noticed, where he has difficulty in blowing from the mouth. And when he presented to us at 8 years, he still could walk. He can get up from the self with the help of support, and he can go upstairs, but he cannot lift the arms overhead or cannot move the chapatis, and also cannot do any fine movements from the hand. There was no significant negative history in terms of cranial nerve weakness. In terms of that, mild facial weakness was there, but still he was able to close the eyes. There was no symptoms suggestive of autonomic dysfunction or no significant history suggestive of sensory disturbances. And birth development was normal. Family history was initially, when we have seen, he was told to be that he was the only one affected. Examination shows normal anthropometry, mild wasting, but he has got mild facial weakness. He has wasting of the limbs, upper limb, lower limb, trunk, as well as clawing of the hands, thenar, hypothenar, as well as first dorsal inertia were wasted. Bilateral wrist and foot drop was there. This relatively preserved calf and quadriceps. However, there was no contractures. There's no trophic ulcers, no palpable nerves. There was no, he has a mild facial weakness where he could not blow properly. Rest of the cranial nerves was normal, speech was normal, and he has got clawing, and he had a positive Romberg's as well as Gauber sign. He was hypotonic, markedly hypotonic, and he has predominant distal weakness where there is a marked weakness of fingers, wrist, and especially in the ankle, dorsiflexion, plantar flexion both. And he has got areflexia. And this is the representative pictures where you can see the amount of thinning he developed of arm, forearm, as well as clawing. Similarly, he has got pes cavus as well as wasting of the calf as well as foot muscles. This is a one video which I want to show that this his like wrist was completely flail and dropped, and this was his gait. Like he can stand with support. However, once you remove the support, he was not able to stand steadily. He would like continue to be unsteady. His foot was outward deviated. There was no movement at all at the ankle dorsiflexion. These symptoms worsened with eye closure, where he would tend to fall. This father needs to support him. So this was his phenotype when he presented to us at 8 years of age. Other sensory examination was normal. He does not report any significant abnormality in joint position and vibration. Rest of the systemic examination, autonomic nervous system and orthostatic hypotension was not there. So with this progressive onset, which was like in 2.5 to 3 years, with progressive, starting with upper limb, followed by lower limb, with clawing and little pain, with marked distal weakness, progressing to proximal weakness. And on examination, he was hypotonic, areflexic, with unstable flail gait. And sensory examination was normal, except that this unsteadiness was increasing on eye closure. So a diagnosis we thought of initially in this child, where he has a symmetrical motor weakness from upper limb onset with marked amyotrophy, and very distal sensory involvement was there. So we thought of CMT versus distal HMN, and CIDP we also thought of because of is it being treatable condition. So nerve conduction was done, which showed not recordable potentials in the lower limb. Median, ulnar, tibial and peroneal was not recordable. Sensory snaps was sural were absent, and median snap was recordable, which was amplitude was low. However, it was remain uncharacterized at that point of time. MR brain was normal, spine MR was normal. We did CSF to look for protein, which was also absolutely okay. B12 and all we have seen. So now we had the uncharacterized nature of severe motor, possibly lower limb dominant sensory polyneuropathy of uncharacterized nature. Initially, we have given a trial of IV agent steroid that did not show any response. Next visit, we saw the mother in the OPD. Initially, she was not present. What we have noticed that she did not report any kind of weakness, but she has this wasting in the both the hands as well as feet, where we can see that she has got an ulnar clawing of the hands, which is more on the left side as compared to the right, and she has got weakness of wasting of thenar as well as hypothenar and first dorsal interosseal. And similarly in the foot also, she has got more on the left side with a bit of clawing as well as deformity of the foot with pes cavus and medial adduction of the foot. So, but she did not report much of symptoms in the terms of sensory as well as motor symptoms. We did her NCS also, and what she had was we can see her latencies were okay in upper limb. Lower limb, definitely peroneus was not recordable. In the tibials bilaterally, she has got normal latency, but amplitudes were low, reduced to 4.8 and 2.6, and velocities was okay, like 41 and 45. In upper limb, ulnar side was more affected as compared to the median side, where you can see ulnar latencies are okay. She has got reduced ulnar potentials, Cmaps, velocities was okay. And among the sensory, she has got reduced amplitude of the sural bilaterally, velocities were okay. So we thought of it's a symmetrical polyneuropathy, lower limb predominant, ulnar predominant, and CVs were normal, and she has got axonal pattern in motor and sensory. So this was probably she has motor and sensory axonal polyneuropathy, symmetrical. So now we have further information that the child has uncharacterized sensory and motor polyneuropathy. Now we have an autosomal dominant inheritance with mother also showing predominant axonal form of neuropathy. So now we come to the differential diagnosis of autosomal dominantly inherited neuropathy, predominant motor with some evidence of electrophysiology, evidence of sensory involvement. So we with upper limb onset. So we keep a possibility of CMT2D, possibly related to GAS gene mutation. And we also kept a possibility of distal HMN5, possibly related to GARS and BSCL2. These were our predominant possibility. We also thought of some other genes which can present with upper limb onset presentation, but there was no associated human signs. We went ahead with the nerve and muscle biopsy. Muscle biopsy showed a neurogenic atrophy, and nerve biopsy showed axonal loss with marked increased fibrosis around the perineurium. There was no demyelination or vasculitis or no myelin abnormalities was noted. So then we thought of if we run this case through this algorithm, then we have a CMT which looks like an axonal, which is autosomal dominantly inherited with CVs more than 38 centimeter per second. So we are left with these genes as well as with distal HMN, where we thought of GARS and BCLS gene with upper limb involvement. So these were our differential diagnosis in this case. We strongly thought of GAS gene related CMT2D or distal HMN because initially there was some pain. It was pure motor process, clinically upper limb onset with the TNR as well as first dorsal interosseous weakness, minimal sensory symptoms. And similarly for distal HMN also we thought of upper limb onset, but there were no human signs. Minimal sensory symptoms. Clinically, there was no sensory symptoms, but she has electrophysiological evidence of sensory involvement. And so then we look at the literature, the neuropathies which can cause predominant upper limb involvement. This was rare presentation, and 4 cases in this series reported with GAS gene mutation, and 1 was with SH3TC gene CMT4C, but there was no demyelinating feature in our case. So we are still stuck with the GAS gene mutation in this case, clinically suspecting this one. So this was the literature. We could see that GARS can come similarly with the marked ulnar clawing, split hand kind of features, and which can progress and has onset variable from like first decade of life towards 19 to 20 years of age, and predominant motor symptoms are there. So we did the whole exome with trio in this case, and initially we found a GAS gene mutation, but when we did the familial segregation, we were not very sure. Mother has the same variant, index patient has the same variant. The second number boy remained unaffected, but he also had this variant. The third sibling was unaffected, there was no variant. Fourth girl, when we saw her in follow-up, by 5 years she also started having complaints of pain in both the arms, and which caused her difficulty in sleeping. She would get up frequently, and she also started developing deformity of ulnar side of both the hands. So this girl was negative in the variant. So we were still not sure about GARS, and we classified this as a BUS, and still we continue to work up this case further. And then we again requested through a research facility where they could do a full familial trio along with the detailed analysis. So we came to this genetic diagnosis in this family, where they found a genetic variant in CADM3 gene, which was like tyrosine at 172. This is a reported variant recently in a brain, and it was reported as heterozygous missense variant and likely pathogenic. And when we did this segregation in the family by Sanger sequences, now we could find that the mother was affected. She has this heterozygous variant. The boy was affected. He has this heterozygous variant, and the sibling number 4, what she was 5-year-old and she started having these symptoms, was also affected. So in familial segregation, we could find that this gene was fitting with the clinical phenotype and as well as segregated in the family. So this was, we considered, could be a significant variant. And this is the same variant which is reported in the literature. So we come across this study published in the Brain in 2021, where they've reported CAD-M3 variant causing CMT with marked upper limb involvement. So what they have reported that this is a like adhesion molecule which is involved in the glial as well as axonal cell interaction, and they have reported 3 unrelated families, the same variant like tyrosine 172, the same variant which we found in our case, and the phenotype was consistent of autosomal dominant CMT axonal pattern with marked upper limb involvement with motor and sensory component. So if we see this table, this is the clinical phenotype what they have presented. This case number, family number 2, case 1 fits with very similarly to us, where the onset was early infantile 3 to 4 years. Patient was examined at same 7 years of age, where the distal weakness was 0. The grade was like MRC 0. Approximal was paired, and upper limb were 4 to 5. That was and there was no sensory abnormalities, and there was no UMN signs, and age of onset was 3. Some of these members also find to have brisk reflexes, and so we thought this could be a good variant and was segregated in the family. So we considered this could be responsible for in this family. So for this variant, not much literature is available. Only 3 families has been reported with the same variant. So that's why we decided that we should seek expert opinion that what do the experts feel. Initially, we thought of GARS because of lots of motor like gait instability, which this patient has, like flail gait with flapping. And then we initially thought of GARS, but this turned out to be CAT. So I just want to take opinion of experts that what is their take on this variant. Thank you so much, Anne, for giving this as a question.
That's a fantastic case. Dr. Manoj, would you, and Dr. Sharath and Dr. Shruti, would you want to make some comments and close this evening?
Sorry, I'll take the liberty of going first. That was a fantastic case presentation. I really enjoyed that. I agree. Firstly, the clinical phenotype is an upper limb predominant sensory motor axonal neuropathy, predominantly motor. I think most people would agree that even for distal HMN, some reports allow mild sensory involvement, like just bilateral sural involvement is allowed within that classification of distal HMN. As Dr. Suthar said, a number of genes are set to go with that, GAS, BSCA2, sometimes mitofusin. We published our cases of distal HMN, and we found mutations in GAS, BSCL2, BICD2, and dynein heavy chain. I've talked to Mary Riley, who's an expert in the HSPBs, and they've never had someone who has presented in childhood. So I think HSPB1 and HSPB8 would be uncommon. So I think you're on the right track with phenotyping this as a distal HMN with predominantly upper limb involvement. I have never seen a patient with CADM3, but as you said, there's only 3, but your phenotype's a perfect fit. So I think you're on the right track. They're very interesting. So thank you for sharing that case.
So thank you so much, Dr. Manoj, especially a big thank you to you and to all our all our delegates who've been there and participants from overseas, as well as the chair people. But a special thank you to Organization for Rare Diseases India, who have made this possible, because this platform is a paid platform, which they are making it available so that we have increased awareness for rare diseases. Thank you so much to RDI. And so it looks like we've just had half the cases discussed. So we are going to have a session 2, which is what we suspected we would have, which would be the last 4th Tuesday of next month, which will be October 24th. So the 24th of October would be 25th of October. 25th of October would be our next session, and it looks like it's going to be neuropathy again. So that's, I never thought neuropathy would be so interesting, Dr. Naveen. Dr. Manoj, I can see why you fancy it so much. Thank you so much. And you had 87 people who were interested and who were there. We've never had more than 30, 40 people. So thank you, everybody.
That was fantastic. Thank you for letting me join in.
No, thank you for being there. Thank you, everybody. Good night.
Thank you.
Thank you, and good
Thank
night.
you. Great sessions.